As South Africa enters another phase of lockdown to arrest the COVID-19 infection rate, world-renowned epidemiologist Professor Salim Abdool Karim says the country should brace itself for a new normal. South Africans are already speculating about a further extension, but the chair of government's Ministerial Advisory Committee on COVID-19, Salim, says it's too early to tell. He does emphasise, though, that our timeous response to the COVID-19 pandemic was a reflection of the strong academic and research capability that South Africa has. He joins us now via Skype to track the country's trajectory and what stages we'll be going through. A very good evening to you, Professor, and thank you so much for speaking to us.
Good evening, and good evening to all the viewers.
Okay, let's just get something straight before we talk about where we are. We've seen in some cases that obviously the National Health Department is the main center that releases official information on the number of cases. We get those updates daily. Some are complaining the fact that there's no reflection of the districts. But we have seen in some cases discrepancies in the numbers that are given, and some even at a provincial level, for instance.
Yes, in the nature of what the Department of Health is doing is that there will be large variations
on a day-to-day basis. That's to be expected. And the reason for it is very simple. There are large variations in the number of samples that are coming in. There are large variations in terms of when the tests can be done and when they can be verified. And so there are many variables that define when results can be released. And so the day-to-day variability must just be expected. That's just part of it. So you shouldn't look at the data by the day. Instead, you should really look at the long-term trends. And you should look at the data in terms of the weekly statistics. And that's what I tried to do. I tried to show that it's more useful to look at them week by week so that you avoid a lot of the background noise. And if you do that, you begin to see a much clearer understanding of how the epidemic is changing and how we can better understand what is going on.
Okay, so if we're to understand what is going on, you have mentioned, or rather at least answered the question on why South Africa is not on the expected COVID epidemic trajectory. What is our current epidemical trajectory?
So it was fascinating when I looked at the data that South Africa took an odd turn while every other country just had a continual increase. So once you get to about 100 cases, there's no going back. It's just the epidemic curve just keeps growing. Mm-hmm. And our country, for some reason, didn't do that. And my job was to try and understand, firstly, why did it do that? And what's the reason? So the first was that I initially thought, oh, it's just a mistake or it's just random error. And then I thought, no, maybe it's just that we're not doing enough testing. And I looked at all of those variables. And initially, I wasn't convinced that it was real. But after 2 weeks, and after 2 weeks of consistent plateau, on top of all of that, that this plateau occurred while our testing was going up, that convinced me that there was something more to this, that it wasn't simply a matter of we were not testing enough or that we were perhaps not testing the right people. I think it's a combination of things. But predominantly, when I look at especially its timing in terms of when it occurred, that told me that it's largely as a result of our interventions. And our country's interventions actually are a combination of many things. It's not one thing. It's not the lockdown only. It's a combination of the state of disaster and the closing of the borders, the introduction of hand washing and social distancing. It was closing the schools, reducing the gatherings, closing places of worship. All of those created the conditions so that the virus couldn't spread fast enough. And it was just taking hold. So the question I asked, I said, so why is it we got this? Why didn't any other country do this? And the answer came to me only after I looked carefully at what had happened. And that was that every other country, they simply saw the epidemic when the patients started arriving at the hospitals. And when you wait for that point, it's too late. That if all you're doing is sitting in the hospitals waiting for patients to arrive, when they start arriving, they arrive in large numbers. So we needed to do something different. And that difference is that we have to go into our communities. We have to look for the virus. We can't wait for them simply to come, because if we did that, and we did that initially, we were starting to see the cases arriving. And so I think a combination of several things. One is early and decisive action. Second is that we did the right things at the right time in terms of choosing very carefully what combination of interventions we chose. And then I think finally that we have certain things that are unique to South Africa.
Okay.
And here I refer specifically to our apartheid spatial distribution, so that the first epidemic, the infections that occurred in the travelers, that didn't seep sufficiently into the general population. And that's probably just one aspect of our history and probably is a contributor.
Okay. So, Prof, we're going to take some questions from our viewers. We'll probably take calls as well. And if you could also, while answering some of these, and I know it's going to be several questions, but I will remind you if you need a reminder. Firstly, you did say that weeks 10 and 16 were very pivotal in terms of our journey, but you did say that even though the curve has been interrupted, we can't escape the exponential growth. A question from Tapelo Gilboy Mukwena saying on Twitter, what do you think in terms of the pandemic in ending or slowing down? So if you could just give us your views in terms of that trajectory. Justice is also saying, how can the coronavirus cell entry occur as compared to the mode of human cell entry by HIV, trying to establish if there's a big difference. So let's just start with those three questions and then we'll move on to the others.
Okay. So as for the global pandemic, we are now almost at 2 million cases globally. I have little doubt that we still have a long way to go. I think we're going to see a particularly harsh or substantial increase when some of the biggest countries are impacted. And here I'm referring particularly to countries like India, Indonesia, and Russia. That as those countries develop advanced epidemics, we will see pretty large numbers of infections occur. And it's almost inevitable because our entire population is at risk. We have no vaccine. 4 months ago, we didn't even know this virus even existed in the world. So none of us have any protection against it. So I think we will see substantially more infections, millions more. Mm-hmm. And that I can't see us escaping. With regard to how does this virus differ from HIV? So both HIV and this coronavirus are single-stranded RNA viruses. The big difference is that HIV is a retrovirus. And what that means is that it carries an enzyme called reverse transcriptase. And reverse transcriptase enables HIV to convert its RNA into DNA. And that's where its DNA is integrated into human DNA. The coronavirus is not a retrovirus. It has no reverse transcriptase, and it has no DNA in its replication cycle. Instead, it uses a different enzyme called RNA polymerase, and it makes copies of itself. So it never integrates into humans. It has no long-lasting effect in terms of remaining integrated in our bodies like HIV. So, in other words, we can get rid of this virus with our antibody response, with the way in which our bodies are able to clear viruses. We have no such protection against HIV. So there's quite a big difference. The problem with this coronavirus is that it spreads through the respiratory mode. And so it spreads much faster than you would see with HIV. The second is that with HIV, from the time you get infected to the time you get disease, that gap is 7 years. In other words, you get infected today, you don't get sick until 7 years later. In the coronavirus, you get infected today, you get sick 7 days later. So in HIV, what takes years, in the coronavirus takes days. And so you have this real sharp increase in the number of patients falling sick. And that puts pressure on our healthcare system, and that's the burden. There's also another difference, which I'll just end off with, which is HIV enters the human cell through a very specific receptor, the CD4 receptor, and a co-receptor called CCR5. The coronavirus uses its spike protein to attach to the cell and enter the cell, and it uses that cell to make copies of itself. So they're quite different in the way they interact with the cells and in the way they reflect themselves in clinical disease.
So, Prof, then there's another question here just along that line, and I think this one is about polio. I'll get to that in just a moment. I've just got quite a number of these messages. But I did ask earlier on about the law of averages, just in terms of the number of infections per week. What numbers do you come to? And another question from Pat is talking about this calm before the storm, which is another question that I asked about whether or not we can avoid that exponential increase. So let's find that question about the polio virus. So Lesang Bokhatsu says, Prof, what is your view on polio vaccination and hydrochloroquine being probable vaccines to COVID-19? Dr. Robert Gallo has said polio vaccine could hold a key.
So I haven't seen what my good friend Bob Gallo has said. He's a very wise man, and so I would take whatever he says quite seriously. But as it stands right now, we have no effective way of treating the coronavirus. No matter what you will see in social media or in any form of communication, there is no evidence that any drug works in treating the coronavirus infection. There are anecdotes, and there are some little studies which are inconclusive, but there is no evidence for us to recommend any specific treatment, including chloroquine.
And does that also include, Prof, I need to ask this because it's also another question that has come in around Dr. Shivu's modern immune therapy. This is a question from Pososo.
Repeat the question. I have no idea what this is.
I also don't know, but I thought you might. He says, what does your guest think about Dr. Shivu's modern immune therapy vis-a-vis conventional methods of curbing virus infection, and is there a scientific rationale for South Africa's very low mortality rate relative to other COVID-19 ridden countries?
So in terms of this particular medicine or immune booster or whatever it is, I don't know of it. I haven't seen any research papers on it, and so I can't really comment.
Okay.
I would just make a more general comment that there are many people selling all kinds of snake oil kind of treatments. Beware. Those are charlatans. They are trying to make a quick buck out of you because they know when people are desperate, they'll do anything. And so I would say there is no nutritional supplement. There is no traditional medicine, and there is no any kind of immune booster that has any proven benefit in the coronavirus infection. You're just wasting your money buying those things. Now, let me deal with South Africa's mortality rate. When we look at our actual number of cases, and we're roughly at around 2,500 or so cases, our mortality rate is running at just over 1% of that. So if you're looking at a mortality rate at a global level, it runs at around 1 to 2%. So we are pretty much on target in terms of where we should be in terms of the experience of other countries. What is an issue is that some countries, older people were disproportionately affected, and they have a particularly high mortality. And we saw that particularly in Italy. So in Italy, large numbers of old people acquired this virus. And in acquiring this virus, old people have a much higher death rate, a much higher what we call a case fatality rate. Case fatality rate is about, of all those who actually became infected, how many of them died. And so it's a proportion, and it allows us to get some idea of what fraction of those who get this virus are likely to die. In other countries, like Germany, large numbers of young people got infected. It just happened that the virus came to Italy at a time when large numbers of young Germans go to Italy and Austria to ski on the slopes. And so they acquired the virus, and of course the virus is much milder in younger people. And so the large proportion of Germans who got infected tended to be younger, and so they have a lower mortality rate. So it's a reflection of who's getting the infection. If you look at most of the people who are dying in our epidemic, they're mainly older people. In fact, I saw a statistic 2 days ago in Switzerland. 97% of those who died from the coronavirus were above the age of 60. Give you some idea.
Okay, so Prof, there's a question about targeted testing, including whether or not certain sectors or certain areas you should have less stringent measures on them if you are to arrest the disease. And I think that links very much closely to when we look at the trend, what phase are we going into? The question has been about the average of infections per week. What do those numbers tell us? And if there's a discrepancy, does it affect how bad it's going to get?
Yeah, I think when we're trying to understand the disease, we, in mathematical terms, in epidemiological terms, we talk about the reproductive rate of infection, which means basically for every infected person, how many other people would that person infect? So if I have the coronavirus, how many people will I spread it to? Because if I spread it to only one other person, then basically this epidemic won't grow. If I spread it to more than one other person, the epidemic will continue to grow. If I spread it to less than one other person, the epidemic will decline. What we have been seeing in terms of cases is that roughly our reproductive rate is hovering around the 1. Sometimes dipping below, sometimes above. It's basically around 1. So that's a good sign that what we're seeing is a situation where we basically, an infected person is infecting one another. Now, of course, that depends on whether we have an accurate number of cases, and that depends on our testing. And we need to be doing a lot better in our testing. We should be doing much more testing. But for now, at the minimum, we have a pretty good idea that even though we're increasing testing, we're not seeing increasing numbers of cases. And that's a little reassuring. Doesn't obviate the problem that we're not testing enough, and it could be that there are missed cases. But for now, it gives us some comfort that we're not seeing additional cases. So it's really that particular phenomenon of the reproductive rate that gives us some idea of how this epidemic grows. So if I look at that, then that tells me, we are hovering around the 70, 80 cases, and the variability around it is quite high. So if we are looking at, anything in pretty much around 100, below 100, we are doing pretty well. Because remember, in every other country, it just grew exponentially, and we haven't seen that exponential growth.
So obviously the questions continue around smoking, whether or not you're more vulnerable to infection because of that. And another question asking about how far are we in terms of the R0 infection system. That's from Alex Mutabo. So if you can also just explain what that is. And Prof, just looking at post-lockdown, people are already there. So what does this mean? Does it mean that we would have pretty much obliterated the high infection rate, even if we're not testing enough, as you've said? And people are also concerned about young children because they pass on infections very quickly. How do we protect them?
Okay, well, that's a lot of questions. Let me see if I can get through them. So the first question is about cigarettes. So given that this virus grows in the lungs and in the nose and the back of the throat, if you have any kind of lung disease or anything that compromises your lungs capacity, then that's a problem. Now, I haven't seen any specific data on whether smokers have a much worse outcome from the coronavirus. So I don't know the scientific data. Actually, I would have seen it if it existed, but I don't remember offhand if I've seen anything to that end. But on first principles, I would have little doubt that non-smokers will cope better with the coronavirus than those who smoke. So if you're a smoker, if you're worried about coronavirus, I would put your packs of cigarettes away for a little while and only take them out once this epidemic is over. The second question was about R0, which I've already explained. R0 means for every infected person, how many other people they infect, and our R0 is hovering around 1 at this point, just very crudely. Then the next question was about, goodness, remind me.
Okay, so let me remind you, Prof. So it's about, what happens post-lockdown. People are concerned. If the lockdown is lifted, what does it mean for infection rate? I mean, people are still asking about whether or not if you're asymptomatic, can you pass it on? But most importantly, children, they tend to pass on and catch infections quite quickly. Does it apply in this case? It's also being winter. People are worried about that.
Absolutely. And, thankfully, I don't make any of those decisions. And, simply put, we would contribute, if asked, to any discussion on the post-lockdown process. But it's not something I'm involved with or have any knowledge of. So what I'm going to tell you is what I think should be things we should consider in the post-lockdown period. So the first thing is that I think it would be most unwise if we have an abrupt end to the lockdown, where we simply tell everyone, okay, tomorrow go to work and, go to school and so on. I think that would cause quite a serious potential problem in that we may have a rush of transmissions and we may undo all of the good work that has been achieved during the lockdown. And so I would avoid that kind of scenario. I think the better approach would be to go for systematic easing of the lockdown. And when the president announced that there was a 2-week extension of the lockdown, he specifically mentioned the issue of easing the lockdown in some kind of systematic way.
Okay. So, Prof, in a word, would you encourage a further extension of lockdown?
I think the lockdown has achieved an enormous amount. I mean, the fact that we didn't have an exponential epidemic, the fact that we have quite low levels of community transmission at the moment from all the evidence we have, I think this lockdown has achieved something that I never anticipated it would. I have to say, it surprised me even that it had this strong a benefit. And now that I've seen its benefit, I'm not sure whether we're going to benefit much more from it.
Okay. All right. Thank you so much for speaking to us, sparing us your time and giving us your insights. Thank you so much for that, Professor Salim Abdool Karim. He is a chairperson of Government's Advisory Committee. And thank you so much to all of you for participating and sending your questions. I do apologize we weren't able to accommodate everybody, but I hope that you got the answer.